We'll go ahead and we'll move on now to our second presentation. That is the project discussion. So that's from Dr. Tria Haggerty. And she will be speaking about the interdisciplinary care for comorbid conditions of back pain and obesity, utilizing care navigation. Dr. Haggerty, it's yours.
Okay, this just to let you all know, I am a family medicine physician at WVU, but I practice obesity medicine both with family medicine, but also in the institution clinic through the internal medicine department, medical weight management. My co-PI on my previous NIH grant was Kara Sedney, and she is a spine surgeon at WVU through Department of Neurosurgery. And our previous work had to do with the opioid prescribing limiting law and the perceptions of that from patients, providers, and pharmacists in the state. And so this is kind of a follow-up based on some of what we found in that study, and also taking our strengths clinically and putting them together to help our patients, we hope. But this is brand new, what we're just starting to think about. And so I will take any feedback, any thoughts, questions, anything about it. So background, with our patients, we do know that there is a linkage between back pain and obesity. Some previous studies, and most of these were recent, have found that there's obesity was a significant and independent factor of low back pain severity. We know that higher body weight does have is a risk factor for chronic low back pain. But then also, we also aren't very good at bringing this up with patients. Like, I think all of us have heard a patient say, I went in for back pain and they started talking to me about weight, so I'm going to have to find a different doctor. They felt like they weren't listened to, and that's totally understandable. So we have to figure out good ways of approaching this with patients and approaching it well. Now, one of the other things that we found is that, this kind of goes into the same thing, that there's obesity and back pain linkages, and there's also emotional disorder can play a role into that, into exacerbating that. Now, this is a publication, it's been accepted. It should be coming out in October, I think, with the Journal of American Board of Family Medicine from our previous grant. And in this publication, we had found themes about challenges physicians had identified with taking care of patients with opiate use disorder, prescribing chronic narcotics. And the title of the paper is kind of what I was wanting here. This was from the physician group that we did an analysis on this. So it's 20 physicians, 10 were primary care and 10 were specialty physicians throughout the state of West Virginia. The quote of the paper, that instead of making me take drug diversion training, why don't you make me take a 3-hour course on how to treat pain without a narcotic? There was a lot of talk amongst our participants in the study that kind of frustration over, we're being told to identify the diversion, we're being told to do this, but how do we take care of the patient? Like, we need to take care of the patient and the current pain they're having, or the continuum between addiction and pain. So part of that goes into what we have been thinking about doing with our clinical strengths. So the overall idea of the project is that we will bring our 2 clinical strengths together. So right now, it's disconjointed, of course. So there's back pain being taken care of over in, of course, in pain management too, but spine sees a lot of back pain. And they see a lot of back pain that's not surgical, which can be an issue for them. Patients are coming in thinking they're getting a surgical consult, that surgery is going to help them. And then the surgeon's saying, surgery may not be as helpful, but some of these lifestyle things can. Then the strength of our clinic, Dr. Davison, Laura Davison, is the chief of obesity medicine at WVU and developed the medical weight management clinic where I work. But the strength of our clinic is taking care of obesity as a disease in our state. And we do that through the 4-pillar approach that's evidence-based. So nutrition, movement, behavioral change, and medical. We are looking at psychosocial factors. So a lot of what we're looking at is what Dr. Sedney is discussing with patients as needed change. So in the process of this, we have started sending patients kind of back and forth based on patients who have obesity and back pain and specific ways of helping treat them between us, but that's disconjointed. So the thought is that we will bring our clinics together. So have a comorbid condition clinic where we see patients with back pain and obesity. We see them together in a multidisciplinary clinic. And in the hopes of doing that is that we can appreciate taking care of the patients more comprehensive from what might be affecting their health. So that we're hoping to do that whether we study it or not. We want to pull our clinics together for that reason, no matter what. And the hope is that this is something that can be helpful to primary care physicians in the state. Both of us have been doing a lot of telemedicine. Actually, in medical weight management, over 60% of our clinic visits are telemedicine at this point because we're taking care of patients throughout the state. So we're hoping that this could be a service that would be helpful in our state. But from the research side, we want to look at when we pull that together, we want to evaluate the effect of the combined treatment on low back pain, disability, and physical function. So like I said, the plan would be for the clinic to be through a multidisciplinary clinic, 100% through telemedicine. We hope to do this as a service to the state. And then one question that I'm kind of throwing out to the group is about getting these patients into the clinic, whether that's through patient navigation to see if patients need to go into spine or into only medical weight management or where they fit into both, but that kind of stuff. The second aim we're thinking about is to evaluate the effect of combined treatment on weight, BMI, and well-being, using standardized surveys, of course. And then just the exploratory aim, understanding positive and negative determinants to intervention, implementation, scalability in rural underserved locations. So this has been something that we've talked a lot. I know we've met with Dr. Lewis and the PBRN team to kind of discuss how this could lay out in the rural clinics for getting patients seen with us. I think that was all. Yeah, that was all I put in there. So of course it's very early, something that we're starting to think about, but I thought I would open it up for any questions or comments or thoughts, anything that could be helpful to us or you all as we think through this.